Medtronic technologies impacted more than 72 million people in the last year, equating to 2 people every second. Harnessing the power of technology to take healthcare further, each technology has unique benefits designed to serve patients. The goal of this program is to get closer to the patient and delve into the challenges and impact of each technology in practice. This is the Medtronic MedEd Learning Experience. No monitoring system should be used as the sole basis for diagnosis or therapy, and they are intended as an adjunct in patient assessment. Reliance on a single monitoring system alone for patient management is not recommended. The contents and conclusions of the following programs are solely those of the speakers unless otherwise cited. The speakers are responsible for all content and any necessary permissions. The speakers receive funding from Covidian LP, a Medtronic company, for this speaking engagement. Medtronic's medical education programs are offered to provide attendees education on FDA-cleared indications and use of our products when applicable. For this segment of the series, a discussion on patient safety in procedural sedation. What are the financial implications of respiratory compromise in procedural sedation? To help answer this question are procedural sedation nurse Linda Erfle, CRNA Brian Berry, and gastroenterologist Dr. Ashish Chawla.
So Brian, in every healthcare system right now, we are talking about cost containment. I can't tell you about a business meeting that I haven't gone to where we talk about reducing expenses with procedural sedation. Can you describe to me the financial implications of respiratory complications and its cost currently on our healthcare system?
Dr. Chawla, great question. Respiratory compromise is a costly issue. When the average industry standard for an organization, a healthcare organization, the profit margin is about 1 to 3%, 2%, you're doing great, right? That means you keep 2 cents of every dollar you take in. When you have a patient experience respiratory compromise, everyone knows because the average, and you can see it right here, the average is about a $7,000 higher cost and a day longer in the hospital. And again, there's other articles and other publications that say a patient on a general care floor will likely stay an additional 7 days, a patient in the ICU 3 days. But again, this particular publication said about $7,000 one additional day. I've seen up to $15,000 to $30,000 depending on the patient's respiratory complication. So very, very, very costly, and it will get everyone's attention on unanticipated increased patient length of stays because all of a sudden your procedure, your operation, your surgery went from the black to the red.
So Brian, as a follow-up, what do you think about the immeasurable costs? So I know we talked about the financial implications, but these immeasurable costs that we just don't consider.
And Dr. Chawla, you and I have talked about this. I think there's significant immeasurable cost or soft cost or the cost that administrators, chief financial officers don't even think about when it comes to this. And it's the, okay, you've had to abort a case. So you have to bring that patient back in for a case that had a respiratory compromised event intra-procedurally. Post-procedurally, you've increased their length of stay. So those we've covered. So let's talk about, and you're a gastroenterologist physician. So let's say I'm giving sedation in your GI lab and a patient has a respiratory compromised event. I say, Dr. Chawla, stop what you're doing. I need to bag, mask, ventilate this patient. I've just prolonged your day a half an hour, 45 minutes, in a very bad situation, maybe an hour. I just push back all the patients of the day. I just drained the staff morale. I've probably impacted patient satisfaction from all the other subsequent cases that are now delayed. And now people are on overtime, which is not measured usually in these situations. So the trickle down effect of a respiratory compromised event from the patient delay, the staff morale, patient satisfaction, provider satisfaction is is very significant, and quite often we don't even think about that.
Yeah, I completely agree with you. And I think, one of the things that when I talk to my endoscopy nurses and CRNAs, getting breaks, getting a lunch, or having that interrupted is the difference between staying at a procedural center versus leaving. And we all know what turnover does to our costs, that they make it even more ridiculous. So, Brian, in terms of the actual cost during a respiratory compromise episode, how much do you think we can anticipate this driving up expenses?
Well, from an incident standpoint, I mean, it's a common problem. Look at it. Respiratory insufficiency, arrest, and failure, what we're talking about today, is among the top 20 most expensive conditions billed to Medicare, Medicaid, and private insurance. Again, it's the top five in the top five conditions with the most rapidly increasing hospital costs for Medicare covered stays. So, yeah, it just reinforces this costly problem, and the data speaks for itself. And what we need to do as clinicians, and our challenge to providers and clinicians listening, is to flip flop this data, try to improve the projections of where we are, and hopefully decrease the cost due to respiratory complications.
Yeah, and Brian, I'm going to ask you one of the age-old questions that I get when when professionals come to me. They're often in denial. They just don't appreciate how common respiratory compromise is with procedural sedation. Can you give us some data or expound on this, on how often this occurs?
Yeah, it's a problem that a lot of us don't want to acknowledge. And according to the American Society of Anesthesiologists closed claims data, you are 62% of non-operating room anesthesia cases are judged to be prevented by better monitoring. And I think that that data is impactful, and I think it's significant. I get very frustrated when folks say that they're all in, they want best practice for themselves and their patients, but the administrators or their management won't approve technology that will enhance patient safety. And what I come back to them uh, is it only takes one. It only takes one patient to go really bad. Then you'll be hoping that you had all of the technology, all of the best practices in monitoring available to you. Um, so again, very frustrated when folks say, "I want the best practice. I want what I would do for my mom or grandmother or what have you, yet we can't we can't incorporate this monitor because of," and fill in the blank.
So I guess the question is then, how can we use something like capnography or monitoring to actually decrease cost of healthcare during procedural sedation by reducing respiratory compromise? Does this happen, and can you reference some studies for me?
Yeah, Dr. Chawla, great question. And there's been a host of studies that actually say incorporating monitoring actually reduces the cost of healthcare. Why? Because it makes us more safe. We don't have these patients deteriorate or decline in a moderate sedation or a deep sedation case. The data speaks for itself right in front of you. In moderate sedation cases, avoiding all those near misses or full-blown respiratory failure and arrest will save about $35 per case. In deep sedation cases, it jumps up to $85. There is numerous other studies that we could reference today that actually say by being more safe providers, you will ultimately save money for for your institution, and provide better care for your patients.
Yeah, so when adverse events such as hypoxia, apnea, or what we call respiratory compromise occur, is it actually quantifiable on how much institutions are actually saving by incorporating technology like capnography?
Yeah, another great question, Dr. Chawla. I like to reference the slide right in front of you. The left side is the adverse event, and what we do is take the published rate of that adverse event, the incidence of it. Then we estimate the cost that it it would incur, that adverse event would incur. So in other words, a patient experiences bradycardia, the estimated cost to manage that is about $63. Then the very last column is the introduction of capnography monitoring. And look at the last three: severe oxygen desaturation, short to mild oxygen desaturation, and apnea. We are seeing big impacts if you incorporate best recommendation standards, best practice standards in monitoring. You're actually going to reduce those costs in those adverse events if you incorporate capnography monitoring.
Brian, it sounds like prevention not only saves lives, but it saves money in the end.
I think you said it very well right there.
Thanks so much for your time.
Thank you.
Thank you for listening. This is the conclusion of the Patient Safety and Procedural Sedation podcast series. Please tune in to other series from Medtronic MedEd Learning Experience wherever you find your podcasts.